Hello, I'm Jim Carroll. I'm the CEO of the diaTribe Foundation. It is my pleasure to welcome you to today's online Musings discussion on the revolution and the ongoing challenges of T1D management. Before we get started, I'd like to give a huge thank you to our sponsors of the 2024 Musing series that makes this online opportunity to learn more about diabetes free to everyone. I'd like to thank our gold sponsors, Abbott, Dexcom, Medtronic, and Tandem, and our silver sponsors, Lilly, Novo Nordisk, and of course, Vertex. All of these companies are responsible for the development of groundbreaking technologies and therapies that allow people with diabetes to live healthier lives. And in addition, they also provide essential support so that diaTribe can pursue our mission to improve the lives of people with diabetes through education and advocacy. It's now my pleasure to introduce our moderator for today's panel, Julie Heverly, who is a mother, a person with diabetes, our senior director of the Time and Range Coalition, and a rock star of a patient advocate. In fact, in 2023, she received the Lilly Leonard Award for Patient Advocacy. We're excited to have Julie return as our moderator. I can't imagine anyone more suited with a combination of knowledge and passion and personal experience as we explore this important topic. It's my pleasure to turn today's conversation over to Julie and our panelists. If you have any questions, please put them in the chat area to the right of your screen. We hope to have a bit of time at the end of the discussion to have panelists address a few of the questions. Julie?
Thanks, Jim. You're going to make me cry. Thank you so much. It's an honor and a privilege to moderate today's discussion. As Jim mentioned, in addition to being part of the diaTribe team, which I feel so incredibly lucky to be part of, last month I celebrated 26 years since my diagnosis with type 1 diabetes. So this topic is incredibly personal to me. When I was diagnosed, I was confused, ashamed, completely and utterly overwhelmed. The tools I was given when I was first diagnosed were a Xerox dietary exchange plan. And this was my technology. It was an eject ease tool for my syringes because I passed out every single time I took a shot for the first couple weeks. I was given a glucose monitor and a logbook, which I never completed, and insulins that not only did I have to mix, but I had to eat in order to manage the insulin instead of vice versa. It took me 6 years to meet a single other person who was living with type 1 diabetes who was my age. It took me 4 years before I got my first insulin pump. And it took me 10 years to get my diabetes management in shape where my doctors were okay with me going through a pregnancy. Thank goodness. That is not what diabetes management looks like today. We are so incredibly lucky to be living in a day and age where we have personalized care from healthcare professionals. We have a wide array of insulins, from stable, fast-acting insulins to inhalable, and the possibility of a once weekly basal insulin in the pipeline. We have continuous glucose monitoring systems that check our glucose every couple minutes and tell our watches and our cell phones how we're doing. And we have automated insulin delivery systems that allow dosing algorithms to guide these highly accurate CGMs to keep us beautifully within our targeted time in range for a much larger portion of the day. For me, that's overnight. And we have robust patient communities with people with diabetes who share and advocate for themselves and for others. It has been incredible to watch the progress that's been made over the last 26 years. My life today is significantly better than it was when I was diagnosed. I'm married, I'm the mother of a bright and healthy daughter, and I have a career that enables me to help others. I have access to more information about diabetes that I could possibly read and process, though I try regularly. And I recognize how exceptionally fortunate I am to have had the opportunity to advocate for self-education, to work with my healthcare team members to develop a management plan that works well for me and my lifestyle. But you know what? I still struggle. I still struggle to get my time in range where I want it to be and where my doctor wants it to be, and to stay there. I experience diabetes burnout, and sometimes, because of the unpredictable nature of diabetes, I do all the right things. And sometimes I still hover in the high 200s for hours on end without being able to budge those numbers. Because for all the advancements that have been made, and there are plenty of them, diabetes is still a difficult, sometimes unpredictable, and burdensome condition to manage. Today, we're going to be exploring some of the places where the type 1 community has ongoing challenges. We're going to learn from our panelists how we can best address those issues with the current tools that exist. And we're going to learn how we can be empowered to advocate for new tools and better solutions. I'm so excited to introduce our panelists today in alphabetical order. First, we have Heverly Piante joining us, who is the Director of International Insights for dQ&A, a diabetes research organization. Heverly is also an individual living with type 1, and we are so excited for her to join us and be able to share some of the insights from the thousands of people that dQ&A gets to talk to and survey each year, but also to share her personal experiences. So thank you for joining us today, Heverly.
Thank you so much, Julie.
Next, we have Dr. Osagie Ebekozien. He is a diabetologist and a researcher and chief medical officer for T1D Exchange. He will be bringing his perspective as a physician and as a public health expert and an advocate for people with diabetes. Thank you so much for joining us today, Osagie.
Julie, I'm excited to be here. I'm looking forward to a great conversation. Thank you for having me.
Fantastic. Thank you. And finally, rounding out our panel, we have Professor Jennifer Sherr. She is a pediatric endocrinologist and researcher at Yale University School of Medicine, who brings knowledge from her research, her clinical practice, and her own experience as a person living with type 1 diabetes. Thank you, Jennifer, for being here. And thank you all so much for being part of today's discussion.
I'm honored to join you all. Excited for tonight.
Thank you so much. So I did some quick math before we got started because diabetes is a disease of math, right? And collectively, the four of us have 85 years of experience with type 1 diabetes, which is pretty exciting. We have seen incredible advancements. We've all talked about that before tonight. And we really are so incredibly grateful for all of those advancements that we've seen throughout our time. But there are still a lot of challenges. And we all know that type 1 diabetes is a 365-day a year, 24-hour a day, 7 days a week burden with no break and no vacation. Research says that on average, a person with type 1 has to make 180 extra decisions each day related to their diabetes management. I'm sure you guys all experience that, you feel it, and sometimes it's overwhelming. Heverly, can you share with us some of the data that you have from dQ&A's panels about people living with type 1 and the impact it has on their mental health?
Sure. Thank you, Julie. We do have a good bit of data on this. For context, we have communities in the United States of over 15,000 people living with diabetes. And one of the things that we really want to understand is truly the lived experience. And in our communities, we see that a quarter of our type 1 adult respondents report feeling burned out, report feeling that it takes too much effort to manage diabetes. And that's definitely something that I have felt. But beyond that, we also see that about a third report poor emotional well-being, which we use a measure called the WHO-5 Well-Being Index, which is a self-reported measure of mental well-being. And we see that a third report poor emotional well-being, kind of continuing that theme. Nearly 15% report feeling some sense of loneliness or isolation because of diabetes. So it's definitely an issue that we feel, I think, personally, and then that overall the type 1 community can feel.
Is that scale something that clinicians use as well? Is that where you guys got it? So do doctors know that people are feeling this way?
Yes, that's a great question. It is used to assess for depression, and then it's also used in clinical studies for reporting out clinical studies. So yes, it's a by the World Health Organization, and it's to assess depression and the impact of in this instance, diabetes.
Okay, wonderful. Well, Osagie, that's a great segue into the work that T1D Exchange does, because you are asking people who are living with T1D and their clinicians about their lived experience. What's your online community saying about the mental burden of T1D?
No, I think that's a great question, and we have a lot of alignment with what Phyllis shared. I also want to back up there's the perspective of the patient, but there's also the perspective of the providers as well. So, for context, we work with 62 different endocrinology centers in 22 states as part of our improvement network or improvement collaborative. So perhaps I'll start there in terms of that's part of our online community of the providers in this community. Now, one of the biggest challenge our providers face, and including myself in the mix, is what to do with the results of this test and what to do with the results of some of this assessment. So I think a lot of the hesitation on the clinical space is, if I screen for this particular thing, or if I screen for diabetes distress, or if I screen for any of these challenges, I'm handicapped if I don't have exactly a clear sense on what am I going to do next? Who am I going to refer them to? Who is going to help them? Who is going to support them? And I think the backdrop to that is we don't have enough mental health professionals, period. So one of the things I'm hoping that we can really emphasize as a community is we need to advocate for more resources to take care of the mental health aspect of diabetes, of type 1 diabetes, because a lot of times the providers are not asking for this, not because they don't care, not because they don't understand the clinical importance, but because for the majority of the folks that we've talked to and we've had a lot of survey data, I'm not sure what to do with that result, Osagie. If I ask this space, what do I do next? So that's one thing we're working with our clinical community on, is trying to figure out what those pathways for referral looks like, what those pathways for support looks like, so that when they do the screening, they can connect that. In terms of people actually living with type 1 diabetes, we've also surveyed a lot of our online community looking at that, and very similar trends. More than half of our cohorts of people that are in our network have shared that they have concerns about their mental health living with type 1 diabetes. Like, that's been very clear. So we're about 56%. Now, you look at that group, and of that group, only about 1 out of 4 have ever had their provider say anything, even to ask them about that at all. So it just let 22% of our cohort, like that's the question of, I have this concern, I have this mental health burden, but I'm not even being asked in the clinic. And even when I'm being asked, then even a subsection of that, I know asked about the type 1 specific distress or type 1 specific challenges. It's more on the overall mental health. So I think there are layers to some of these challenges. And I hope that as we continue this conversation, let's think about it, not just in finding out what the questions are and the responses to the questions, but more importantly, what do we do as a community to address the answers when we get those answers?
Yes, that is so incredibly important. And that actually leads well into a question I have for Jennifer. So one of the biggest challenges, I think, that impacts our mental health is the overarching fear of severe hypoglycemia. If you have type 1 and you're on insulin therapy, there is a very good chance that you are going to experience lows. We all know this. And you have been a lead author in a study that is looking at the impact of severe hypoglycemic events and impaired unawareness, even with all of the amazing technology that we have access to with CGMs and automated insulin delivery systems. Can you tell us about this study and what the major takeaways that you're seeing are?
Absolutely. So, this was a really interesting cohort. We did a cross-sectional analysis of over 2,000 individuals living with type 1. The mean age was about 43 years old. People had type 1 duration for about 26 years. And what we found is that over 90% were using CGM. This is a highly engaged population who is really, using technology. Many were also using automated insulin delivery. But we found that only 57% were achieving glycemic targets. And that's surprising. So we're really engaged, but there's that struggle to get to that glycemic target. Now, what about rates of severe hypoglycemia? Overall, we found about 20% of respondents had a severe hypoglycemic event. It differed by technology used. So for those not using CGM, the rate was about 34%. When we talked about those who are on automated insulin delivery, the rate was 16%. The important thing here is that the technology we have, which is groundbreaking, it's done so much, it can't completely protect us from hypo. And that's because there's so much human involvement still. I still need to bolus for what I'm eating. I may not eat everything on my plate. I may get distracted. I may exercise. There's those 180 decisions that I have to be going through. And I think one of the things that's really interesting as a person living with type 1, I feel like if I report a severe hypo event, I failed. I didn't fail. It's not on me. The same way we talk about mental health, it's not problematic to say I've had this event. It's going to inform how we move forward. The other thing to note is you mentioned that impaired awareness of hypoglycemia. What does that mean? It means that my blood sugar's low, my natural responses to the low, which is release of adrenaline, that's going to tell me I'm feeling shaky, my heart's racing, go ahead and do something. What ends up happening is that across all technologies used, 30% of individuals still had impaired awareness. We are not taking that away. So we've got to do a lot of work to get rid of that, because not having that physiologic response to tell me, go do something, grab your juice, grab the thing next to you, I'm missing that moment that I'm on the cliff and I can intervene. So we know there's a lot that remains to be done. And I think talking to your physician or provider about what's going on will help us to take next steps for each individual.
Yes, absolutely. Heverly, I know dQ&A also recently released some data, because I was like gobbling it up the other day, just completely understanding and feeling it. Can you share some of what you guys saw with hypoglycemic episodes and the use of technology? It's still
Sure.
there.
Yeah. Actually, kind of piggybacking off of what Dr. Sherr said, it's one of the findings that we found really interesting is over a third of folks with type 1 in our panel deliberately elevate their blood glucose to prevent hypoglycemia during specific events, during presentations, during something big. And to Jennifer's point, I know that when I go to present, we all, I think, before starting this call, went and got a low snack to ensure that we were not all going to tank. I think we've all got them beside us. And it, like, while that community is lovely for all of us to be on the same boat, it is challenging. And when we think about the impact of hypoglycemia, we also see that over a third of our respondents believe that it affects their independence, their sense of independence, and it's causing long-term effects, because if we're elevating our blood glucose before a big event or before a wedding or before we go talk to someone or something important, that's going to impact it overall. And it really does make you feel like I have to make sure that I have my low snack handy, or I'm going to not be in a good situation. So it definitely does also cause some of that emotional kind of turmoil that rises up with diabetes. To your point, Julie, we did just recently present some data at ADA on the incidence and impact of hypoglycemia. And we see that mild hypoglycemia, or kind of that 55 to 70 range, is a near daily occurrence in a fifth of type 1s in our community. We see that moderate hypoglycemia, though less frequent, is still a weekly challenge for over half. So that kind of shakiness feeling, that moderate hypoglycemia that you really feel and that you afterwards kind of feel like woozy, it's a weekly challenge for over half of our respondents. And again, just personally, I know that when I get anxious or when I'm going to present, it's hard to distinguish between, am I going low or am I just nervous because I'm about to speak on a panel? And either way, I'm going to have a low snack beside me. So it's one of the challenges definitely that I personally relate to and that we see in our communities.
Yes, definitely. I mean, we talk about the 42 factors that impact your blood glucose. We all recognize those. Definitely made sure I finished my lunch before we got on the panel, but had a low snack just in case, and may have snuck a small chocolate chip cookie. But I want to go back to something that you said, Jennifer, because I remind my team of this all the time. It is not our fault as people who are living with diabetes when we have these issues. It's the diabetes fault. And so, we have to be empowered to be able to manage that. But we really do have to remove that blame, because there are so many things that are not in our control that impact this. And so, I just wanted to take a minute to stand up on that soapbox. Osagie, I would love to hear from you what you think is missing for the diabetes care community. What do you think, could help lessen the danger of these severe lows and, help the people that you're trying to take care of?
Well, I'll build on the fear of hypoglycemia concern, because I do think it's such a very critical issue, and we see this more in caregivers. We see a parent that has a young one with type 1 diabetes, and as a mom or as a dad or as a caregiver, there's that's fear too sometimes, where like, would this child be low, and even for adults, so a caregiver, an adult caregiver for another adult, there is some of that piece there. One of the main pieces, I genuinely feel that we as a community need to be more vocal about glucagon, the good old glucagon. I think that a lot of conversations with type 1, it's insulin, and maybe most recently some of the other adjunctive therapies, but good old glucagon and the importance of that, and ensuring that with every insulin prescription, let's ask the question of, do you have a glucagon on file? Do you have, and the glucagon is not the typical, way we've always thought about glucagon, and the very scary piece. Now with a nasal spray, you can help yourself and even help someone. So I think that's something that we as a community should think about. How do we promote the importance of not just the insulin and insulin dosing and insulin sensitivity, but the importance of making sure that we have our glucagon readily available with us in person at all times, because sometimes you also can predict when the hypo will go low. And there's some level of comfort in knowing that, look, I have my glucagon in my purse or in my bag, or, it's my child's backpack, and the school nurse understands that this child has type 1 diabetes, and if they're low, they know and understand how to do that. And that's the other piece we're coming at this from. We're working with other partners to really try to educate the school community that are caring for kids with type 1 diabetes, because a lot of, for children particularly, they spend 6-8 hours outside of the home every day. So how familiar is the school nurse with type 1 diabetes, with understanding the signs and symptoms of hypo, being able to respond to that? How about having a buddy, having someone else in their class it's a friend that can be trusted to know that, okay, you know what, James or Smith or Jane or whoever, this is something that you need to pay attention to. So I think that we need, as a community, both the clinical community, the patient community, the advocacy community, come together to think about hypoglycemia is a risk that we'll have living with type 1 diabetes. Until we find a cure, we will still have the challenge of hypo. So what are some of the short-term immediate solutions that we need to promote the same way we promote some of the other things? And I do think that's something that I would love to see a bigger voice on glucagon, and as one of the tools in our toolbox to ensure that we reduce that fear, reduce that concern, and make sure that everyone stays safe.
I could not agree more. I'm embarrassed to say that I went the first 20 years of my diabetes never seeing a glucagon kit. And the new ones are so much simpler to use and less terrifying. I taught my 11-year-old how to use the glucagon, and she feels so much better knowing that if something were to happen, she could help mommy. Mm-hmm. And she likes to hold it over my husband's head, who didn't learn how to use the glucagon, but at least somebody in my house knows how to use it.
Julie, at least yours is not expired, because when I went to teach my room, like I moved in with a roommate and went to teach my roommate, and I was like, oh, this is very out of date. And like I work in diabetes. I have diabetes. My parent has diabetes, and it was not something that, and my provider never brought it up. It was something that I had to bring up. So it was definitely, Osagie, I agree. It literally is life-saving. And I'm really excited for the developments we're seeing there. And need more education and access to it, and to remember to not let it expire.
It does need to be updated.
I sort of feel that maybe at some point we'll be in a place where, as a community, maybe there are even like some big commercials on the TV talking about hypoglycemia and ways for the community members to even recognize some of these. I think type 1 diabetes, we need to amplify our voices collectively, and like, this is how you stay safe. And all those lay people, to your point, Julia, with your daughter, and just anyone, any caregiver, a friend, a classmate, should understand some of those common signs, and like, hey, this is how you respond, because those minutes literally can be life-saving, and we need more awareness on this.
Yes, absolutely. All right. Another challenge I think that we face, and maybe it's just me, but I think that sleep is a real big problem for people with type 1. Not everybody in America needs a lot of sleep, but I myself have a lot of disruptive sleep based on my diabetes. And Philly, I was wondering if you could share any data that dQ&A has about sleep interruptions, or if you guys want to share your own personal stories. I know we're all dealing with this.
Yes. Yeah. So, I mean, I am privileged in a lot of ways to work for dQ&A, because not only does everyone get diabetes in some capacity, but at least half of us have diabetes or have a child with diabetes or some sort of personal connection. So it is, to your point, Julie, very comforting to be able to show up to a meeting and have, my colleagues just understand that it's been a bad diabetes night and you're just not on your A game, and you need a little bit of assistance. But you're not alone. And I remember when I was a year after I was diagnosed, my endocrinologist gave me as required reading a book called Why We Sleep, because she wanted to really encourage me to get the blood sugars overnight locked down. But 42% of the folks with type 1 in our panel indicate that they get poor or very poor sleep. A quarter say they have trouble staying asleep, and whether that's because of you're just not getting into a deep sleep, or because you're CGM is going off and waking you up, we do see that a quarter are having trouble staying asleep. We see that only a third of type 1 respondents are actually satisfied with their sleep quality. So kind of conversely, 2/3 are not satisfied or not feeling like they've got good sleep quality. So it's comforting to have teammates who get it, and it's comforting to be able to work in a space where it's very understood, but it really does. It's hard to wake up after a night of battling lows, and you've got the grogginess of the night and the low snacks and the alarms, and you've got a pile of juice boxes or a pile of wrappers beside your bed, and it just makes it a little bit harder. It adds just a little bit more to the kind of emotional and mental load of a stressful workday or a busy day of meetings or running around to catch a flight. It does impact from a personal experience, and then also in our data, we see it's overarching kind of reach into how you live your day.
It does. Jennifer, do you have any suggestions on anything that we can do? Any hacks that you have on how to silence alarms? I know not all alarms can be silenced, and I do want to get to that in a minute, but just personal sleep. Any tricks?
I think the biggest things here, and I will say I have interrupted sleep still. I will say, I've had diabetes for 37 years. I went on a CGM and I was like, oh my gosh, I'm doing so much better. I went on an AID and I was like, that's what sleep is? I had no idea, right? Like, I was shocked to learn what it feels like to feel rested. And I had no idea I was living with chronic fatigue. I think some of the things, and this has even come out as we have gotten CGM more into clinical practice. When I first got my CGM, I was in the JDRF CGM trial. And I will tell you, I got that thing and I set those targets really tight. It would go off all the time, right? I was going to be really on top of it. 1 week in, I pulled it off and threw it across the room. And so I went back and I was like, we're doing this all wrong. So I think setting actionable alarms, understanding how followers are going to respond. I fell asleep early last night. I treated a low that I happened to have. My husband then called me from downstairs to say, hey, you're low. This is not helpful. So it's talking about how do we communicate to those who follow us? How do we respond to alarms? And I have these conversations constantly in clinic. And so I think it's really personalizing what's important to you, how do we approach things, and then seeing what's best for an individual and changing it as, in my case, kids grow, or a woman may choose to get pregnant, or life is changing. I'm going into an assisted care facility. Hopefully not yet, but all of this could happen to individuals with diabetes, and we want to support them through each stage.
Yes. Speaking of supporting them, I think one of the alarm topics that keeps coming up in conversations that I'm having is the challenge for school-age children who are now facing outside threats, outside of diabetes. And we all know when we're stressed or scared or running through a building, our diabetes is unpredictable. So if alarms can't be silenced, what are the unintended consequences of those alarms? And what advice do you give children or parents or caregivers about that sort of those potential situations? Hopefully nobody finds themselves in them. But, my child does drills at her school, and it's a real concern for families.
Yeah, no, I think it is absolutely a concern. I happen to live next to Sandy Hook. It is very present in our area that people are aware that things like this can occur. And so I never expected to deal with this in diabetes clinic, right? And so I have this conversation on a regular basis. I do not have a great answer. We talk about trying to make sure the pump would be muffled, where can we put it that you were going to limit sounds that may be emitted. But I think we have to really call on regulators, device manufacturers to understand that our world has changed. Safety not only encompasses avoidance of lows, but also avoidance of these situations which we hear so commonly about. And so I think we need to advocate and say there are times we may need to toggle things like this off, knowing that in most instances we want it on. So I think it's just continuing to talk about that, advocate for it, and try to muffle if we are in situations of lockdowns.
Absolutely. Thank you. I'm sorry, when I brought it up, I didn't know that you were right next door. That is so close to home. All right. So I think my final question on this area is just this idea. And Jennifer, you sort of mentioned it when you were talking about your husband calling and saying you're low. I'll be honest, I don't share my data. I should, but I don't, because I feel like it would be a burden to people that are already doing so much to help take care of me. And so, Osagie, when you're looking at all of this device data that you have access to through your clinics and your care teams, can you speak to the mental burden that caregivers and loved ones might experience to this additional, sometimes they call it type 3 diabetes, but then there's also this, active burden of absorbing and trying to figure out when to be helpful and when not to be.
And it is a constant struggle, and I think that's still something we as a community have to continue to figure out together. I'm a follower as well for a caregiver, and I've been cut off and put back on. Depending on if I behave well, I get put back on, and if I misbehave, I get cut off. so it is something I completely understand, and I do think that there needs to be a very frank conversation with, even if it's an adolescent or a spouse or a partner, this is when I want you to respond. This is how I want you to respond. So, if nothing is changing in 10 minutes, call my phone or send me a text. And that's why I find it most helpful. I think if you're a caregiver, a husband or a wife or a spouse or whatever to someone with diabetes, have that conversation very early on. It is a very powerful tool on my phone, and I can see, are you trending now? I'm like, are you trending up? What are you eating? What's going on? So it really, creating that boundaries and understanding, having that conversation before you do have to take an action, so that you don't become like me, where you get cut off and then you have to apologize to get back on again. So understanding that it's a privilege to have that kind of access, and with that access comes responsibility, and with that responsibility comes open communication on where should I be, what do you want me to do, and where should I pull the trigger on, like, you're not responsive, your sugars are really low, I'm seeing 2 arrows down, I need to call 911, I need to call a friend or something. So really understanding that piece, and I think that sort of expands the whole conversation on diabetes, type 1 diabetes, in particular being a family disease, and it's a community. It's not just the individual alone living with type 1 that has to deal with the struggles. Everyone in that immediate primary circle is dealing with this struggle. A grandparent, an uncle, the daughter, the son, and I think understanding that, like, there is that burden and that emotional support that even we as caregivers need to also help support people living with type 1 as well.
That is such a good reminder. Thank you.
Yeah.
And I'm just going to use this to plug an idea that I've had for a while and I think needs to be in there and would help with this communication. I think that if a low alarm goes off, there should be a button that you can push that said, I had 15 carbs. And that way the person who's following you would know, and maybe the algorithm would not, like, they would give time for those carbs to absorb and not eat. I don't know.
Yes. Yeah. There's like a button, like, I've addressed it. I'm aware. I know.
Yeah.
Yes. Because I think also, Osagie, one of the other pieces to that is it can be really hard, at least personally, to share constantly with my CGM, because it's like sometimes I just have a bad diabetes day, or sometimes it's just not behaving and I'm trying my best, but it's just not working for me. And even though it like, feeling like someone else is able to see that can sometimes feel like judgment, even if it's not meant that way. And so I think having that kind of open conversation or having that communication is really so important. But Julie, I agree. I have also had that, like, please give us an indicate, like, give us a way to say, like, I know it's been addressed.
And I do just want to highlight, I think this is all really excellent. I will say, my husband will say, I'm sorry about the day you're having. He won't say anything else. It just means he knows it's a day. He's going to be there when I get home. That means the world to me. But it took time to get to that statement. The other thing I want to point out is that as a pediatric endocrinologist, we go through developmental changes. Yeah. When adolescents, you're struggling for autonomy. I'm setting up contracts. This is when you can contact your teenager. You can't contact at this point. When you head to college, we're going to toggle you off. Let them have their freedom. Do a check-in on Sunday, review reports together. And I think that's really important to allow children to grow and progress through stages normally and feel less burdened by their diabetes. So I really encourage pediatric endocrinologists or parents to talk to their pediatric endocrinologist about how to go ahead and approach that.
I love that.
Great
That's
point.
Fantastic. All right. Another issue that we sometimes have as people living with type 1 is this idea of becoming so reliant on the technology that we have access to that we don't know what to do when there is a break in the system. For example, after ADA, I had the opportunity to go to Harry Potter World. It was wonderful. My pump broke. And so, you go back to square one, you're all of a sudden you're like, I have a backup plan. I'm not carrying it around with me. What do I do? Figured it out, spent the rest of the day there. It was all good. Thank you very much. But we are constantly trying to figure out, what do we need? How do we get access to it? Do we have enough backup supplies if there's an insulin shortage, or if, something happens with our insurance? Do we have enough pump supplies or enough CGMs if one falls off or gets ripped off or whatnot? So Philly, I'm curious if dQ&A has data on this topic, on what people are saying and reporting about having access to enough supplies that they feel comfortable, or is that another added burden to people who are living with type 1?
Yeah, I'm glad you brought that up, Julie. Also, we've definitely had the experience of someone not connecting their pump, and then 2 hours later realizing that they're out and about and not connected. But beyond that, we do see that 60% of the CGM folks living with type 1, so folks on a CGM living with type 1 in our panel, have had some difficulty with refilling and acquiring new CGM supplies. 7% have serious difficulty. And so this is not even a question of getting a little backup or getting an extra, a small amount of padding, but this is just getting what they need. We see that just under half believe price and affordability are at least somewhat of an issue for them, and 1 in 10 report it being a serious issue. So driving towards even providers understanding and building in a little bit of additional supplies. That was something that has been really helpful to me in the past. But having that support from providers, and then also ultimately access and affordability is going to be something that we keep on coming back to, that we absolutely need.
Absolutely. And so this technology is incredibly important, and we're all, embracing it. It has become the standard of care for optimizing type 1 management. But Jennifer, I'm curious if you in the clinic are finding there to be issues associated with the technologies, things that maybe we weren't expecting or that happen after use of the technology for years and years.
So I absolutely see lots of this, right? And I'll point out, as Osagie said earlier, one of the things that I think we need to concentrate on, along with glucagon, is ketone measurement.
Yes.
Right? Because we see infusion site failures, but people will say, oh, maybe it's still working. I'm going to give a little bit more. And then nobody, we talk a lot in clinic about, please remember to measure your ketones. Go ahead and assess where things are at. And people may get behind. And these are instances where people may end up with diabetic ketoacidosis because they're thinking, my technology is going to come in and help me here. Now, we know there are corporations and academic groups looking into developing continuous ketone monitors. That's going to be huge. If I can offset that and get some information that's going to say, think about my site, go ahead and change out things, go to the next spot, that will be wonderful. But the other problem we have, I see kids as young as 1 and 2 years old. I foresee a lifetime of diabetes for them, right? And so we have limited geography. And when we're placing insulin in the same spot, we run the risk of developing lipohypertrophy, which is scar tissue at the site where you continually give that insulin. That scar tissue makes it so that we can absorb the insulin as well. And so numbers get to be more erratic. And so really trying to figure out, how do we avoid this? What do we do to detect it? We always tell people, once it's detected, try to rotate. It's so difficult. I don't know about you guys. My hand goes to a certain spot on my body, and I have to say, move it, because I just have, I'm drinking my cup of coffee. I got to run out the door, and I'm just doing my thing with getting going. And so it takes so much mindfulness to make that small change. That small change can be huge. So how can we look into methods to prevent the development of this scar tissue? How can we try to detect it and encourage people to move and rotate spots? Because these kids, they're going to be 90 someday, right? We need to have lots of geography. And I hope, in the end, that they won't need insulin therapy and we'll have other things available. But until then, I need to keep everybody safe.
Yes, absolutely. Sorry, are you aware of any solutions that are being developed to address, the scar tissue, the site irritations, all of those things that are happening?
Totally. I think that, one of the beautiful things about how much the type 1 diabetes community has grown, it's really the large number of new industry partners that are in the space and are engaged and active and working on this. So I do know that a few of our industry partners are actively researching different options, different kinds of adhesives that can help and that will have less reaction. So, I'm very hopeful and optimistic that we will have better solutions because, for a very few small proportion, we looked at some of our data, I think close to 5% or for people that choose not to be on CGMs, for example, in our database, where the main reason was some of the skin reactions they were having and some of the concerns there. So that's a huge proportion, even, like 4 or 5%, but that's still a good number. So I do, and then even for those that are on it, it's still a constant struggle. So I'm hopeful that with some of the things, I know there are a few things now being tested in trials. I'm hoping that those will be potential solution down the line to really help us move this needle. And I'll use that as a segue to really talk about the participation in clinical studies, participation in clinical trials. because I think it's really important. It's our industry colleagues, our researchers. There's only so much they can do without any of us impacted by type 1 really being a part of these trials, being a part of these studies. There are many ways to get engaged, many ways to get involved. You can speak to your providers about it. Breakthrough T1D hosts a page where, different ongoing clinical trials, you can be a part of it. T1D Exchange. Many other organizations are actively promoting ongoing clinical trials and clinical studies. So when you have an opportunity, please consider it, because we do need you to help us find better solutions.
Yes, it's going to take all of us being part of this. So thank you for bringing that up. I really do appreciate it. We only have about 15 minutes left before we get to the Q&A. And there's one topic that I really don't want to pass up on. So I'm just going to jump into one of the biggest challenges I think there is of living with diabetes. And that is our overwhelming desire to do whatever we can to limit the risk of developing life-threatening complications. I talk about it all the time. I want to be here to, bother my daughter and walk her down the aisle and, see my first grandchild. Like, I want that so badly. That means that we have to take care of ourselves. And I personally want all the tools that are available to me to make that happen. And, we know that keeping our glucose levels in a good targeted range, even keel, not too many highs or lows, is key to that. But we also know that science has made tremendous strides in glucose lowering medications for people with type 2 diabetes. And that those medications, in addition to, really helping with glucose management, also are really reducing risk around the comorbidities of diabetes, the cardiovascular disease, the chronic kidney disease, which are things that terrify me when I think about my mortality with type 1 diabetes. And none of these therapies are currently available and approved for people who have type 1 diabetes. I will say some people with type 1 are receiving them and using them off label, prescribed by their clinician, monitored and utilized with healthcare oversight, which I think is hugely important. But I think that there needs to be more discussion taking place about what's happening in our community or not happening in our community and what can be done. Are there clinical trials? Are there studies? Are there protocols that need to be established to make these miracle drugs, I mean, that's basically what they are, available to people who have type 1 diabetes? So I will start with you, Osagie. Can you shed some light on the full scope of benefits that somebody with type 1 could have from the use of adjunctive therapies in meeting their needs, beyond insulin and beyond, protecting for complications? Are there other things that these drugs do that we need to put in the atmosphere so that people are talking about them?
Totally. I'll start, and I'll make sure I leave some room for my friend Jen to share some insight as well. I think the big piece is we also need to put into context that people living with type 1 are also living with other comorbidities. Obesity is a big challenge even now with type 1. Our most recent data, 35% of our cohort, and I'm talking, we have 97,000 data for 97,000 people living with type 1 diabetes through our clinic network. That's a third of people living with type 1 also living with obesity. And then when you add overweight to it, that's additional 20%. So you're talking close to half of our type 1 cohort having obesity, all being overweight. So these are not numbers in isolation. Where people living with type 1 are also living with other cardiovascular disease as well. So, and that's been part of a little bit of the frustration, if you use that word, because we know that even in the other cardiometabolic space, it is still a risk, it's still a challenge. So that's the one big piece there. I think that as we approach this conversation, type 1 is one thing, but we need to think about, cardiovascular complications, cardiovascular comorbidities. We need to think about obesity-related diseases as well, and obesity-related challenges. And I always tell people to start there. Like if you're living with obesity or you're overweight, talk to your provider about that too, because some of these therapies, this adjunctive therapy, has been shown to have hugely dramatic effects in helping us, because there's a lot we're understanding now about obesity and the pathogenesis of it and the mechanism of it. It's no longer this personal failure of like, oh, I'm overweight or I'm obese. There's so much more we're unraveling about the science of that. So I do think that is one of our current realities. So let's understand that, there are ongoing studies, many of them that I'm aware of, to exclusively answer the question of type 1 and, the GLP-1s, the GIPs, and I think we'll see how all of those unfold, but some of the real-world single-center studies have shown huge improvements in not just glycemic outcomes, but even in some of these comorbidities we're paying attention to. And I'd love for Jen to add some of our voice here too as well.
Yeah, she's shaking her head a lot. What do you want to say?
I'm excited about this topic. I can't even tell you. So I definitely think, this is an untapped area. We deserve access to these therapies. As Osagie said, the rates of obesity and overweight are mirroring the general population. So if I have that, why can't I get treatment for it? And so it's been really great. We've seen information come out. Diabetes Technology and Therapeutics had 2 publications from the Barbara Davis Center showing benefits in terms of insulin doses, glycemia, weight. We haven't seen long-term studies to look at cardiovascular and renal benefits, but there's no reason to think it would be different. And so really, I think that, there's a lot of independent academic investigators doing these studies. Yes. My colleague, Dr. Michelle Van Name at Yale, is doing one in young adults looking at cardiovascular issues. And she is trying to recruit participants, so participate in trials. Yes. In the meantime, we need to advocate to have drug manufacturers recognize we can't be ignored. Mm-hmm. We're not going to be ignored. And so we need to go ahead. I will tell you, I've been on a couple position papers that will come out not too, in the distant future. But we are basically saying at the end of every single paper, we call on industry to do the studies. We need access to these therapies. I also just want to mention, I know we talked about GLP-1s and GIP, but it's also important to think about sodium glucose cotransporter inhibitors. Those are agents that are an oral agent. You take once daily. It allows me to excrete or pee out additional glucose in my urine. And so there's a study that was recently done up in Canada, led by, oh my gosh, I'm going to blank on his name. I'm so sorry. But with that study, they assessed teenagers and they found a 0.5% reduction in hemoglobin A1C in a short duration trial. That is larger than what we see in some automated insulin delivery trials. Yeah. And the kid said, it's not that bad taking a pill. That's wonderful. They said, I forgot the pill. I didn't feel bad about it. I just went ahead and take it. And so the NIH is now actually reviewing grants to go ahead and see how we can use these safely. Part of it through the continuous ketone monitors I talked about before, but be loud, join trials, advocate for industry to do this. I want to see all of this break into the type 1 population. And I will say there's an agent that just got filed with the FDA for an indication of type 1 and individuals who have chronic kidney disease. Yes. And that could be life-changing to just have a first agent approved. So I'm going to keep my fingers and my toes crossed, cross that, finish line with getting a first agent out there.
Yes, I agree with you. I think our voices need to keep amplifying each other's, and this conversation needs to continue to happen. I talk about it in every instance that I can. The other topic that I think I want to try to get to with the few minutes that we have left is this idea that diabetes and our glucose management levels are very much impacted by our hormones, specifically for women going through menstruation, going through menopause, but also teenagers going through puberty. We see that, we hear the horror stories. Jen, I'm sure you're dealing with it in clinic on a regular basis, but I'm curious if there's anything that is being done to address these challenges that exist. They exist for 50% of the population.
Right. So I think it's been very interesting. Researchers have really focused on this of late. We've had colleagues that have gone ahead and done clamp studies to assess insulin sensitivity during different phases of the cycle, so we can learn more about that. They're using modeling studies to understand more that could feed future algorithms. In addition to that, they've leveraged some data from the type 1 diabetes exercise initiative. And they went ahead and looked at women in the follicular and luteal phase, and they found that glucose levels go up in the luteal phase just prior to your menstrual bleed. So we can see it in this cohort of individuals in real world, just tracking everything at home. What I'm hopeful for is there's a small study that showed automated insulin delivery actually mitigated the changes in glycemia that you can see. So maybe that's going to help, but I still think we probably need more personalized algorithms that can go ahead and help us track where we are in our cycles and go ahead and respond more quickly to these changes. So I'm very hopeful that people are paying attention and work is being done.
Yes, hopeful too. Philly and Osagie, do either of you have anything to add on this topic?
I think actually, ironically, I want to kind of also bring that back to the use of GLP-1s or SGLT2s, because one of the things that also is not really addressed or talked about is the incidence of PCOS in people with type 1 diabetes. I have PCOS, and I don't fit necessarily the sorry, the noise thing going on. I don't fit necessarily the image of what someone with PCOS would what a clinician would assume a person with PCOS looks like, but it's true. And Dr. Sherr, to your point, oh my goodness, the way that my diabetes changes its mind when I'm in the luteal phase as opposed to any other phase is it's just incredibly challenging, and it adds again another kind of layer of things. You're already perhaps dealing with all of the other PMSing sort of pieces, and then to also then add in you're incredibly insulin resistant, and also I find just far more brittle. It's up and down way more than it is in a kind of standard phase. And so one of the things that I really am hoping for, or crossing my fingers, toes, and everything else in the future is first of all using GLP-1s and SGLT2s and all that they have in treating PCOS and in managing that, and then also shaving off those crazy highs, because the hanging at 250 that you were talking about at the very beginning, Julie, that's definitely that is the biggest indicator that I am going to have menstruation that coming in the next week is my blood sugars just don't behave. So I really am hoping for better use of adjunctive therapies, and then specifically in women's health. It's something that we've not studied enough. Pregnancy is hardly studied, and the AID systems that exist for pregnancy aren't even great yet. But I'm really hoping for more information and for more research. So again, calling for greater involvement in clinical trials, for greater involvement generally in research, because that really drives it forward for all of us, because again, there's so many of us that are living with diabetes and some sort of comorbidity, or just another piece to the puzzle.
Yeah, and I think that's sometimes overlooked, is that we're not all just dealing with type 1 diabetes. In almost every case, there's something else, and if there's not yet, there very likely could be.
Yeah.
So I've heard a lot today, we need to have as many tools as possible. They need to be as customized and as personal as possible. We need to raise our voices together and collectively. We need to keep educating and advocating for ourselves and for our community. Osagie, what else can you, encourage and empower people to do?
Yeah, I love all the conversations we're having, and I love how we touch on a lot of different key issues. I think about a framework, a socio-ecological framework, in looking at some of the ways we address some of these issues. First is on an individual level, me as a person living with type 1 or caring for someone living with type 1, there are things I can do. And even some of the conversations about the devices and technology, we do have a role to stay engaged, stay informed, stay empowered. So that's something I can do today. Where are the resources? Where can I learn more? Where can I understand some of these newer technologies that this panel is talking about? So I think that's the one piece. First is, what's your role as an individual and in the advocacy space? Then you take it to the second level of our interaction and our relationship with the care system, and in this case, our providers. I really love the conversation and how you started the framing earlier, Julie, with understanding even that your provider has limitations in what he or she knows. And that's the reality, and that's the truth. We've found And in some of our studies, 2 years ago, we published a paper in DTT where we demonstrated provider bias by insurance, by race, ethnicity. And again, that's not pointing the finger at anyone. That's just like stating that, look, we're still flawed humans working in the system like this. And sometimes those biases come out and really impact the work we're doing. So that's the other piece on shared decision making. Understand that like your providers, they do have your best interest, but they might not always, there might be some biases that come in play there. So have that conversation with your provider. On the institutional level, we have a big role to play in looking at insurance access and looking at policies within the health systems that we're caring for. On the societal level, there are big things we need to do as well. So just on the, it's a multi-layer piece, but we can do something today, tomorrow, collectively, to really push this conversation forward. And I'm very optimistic that 5 years from now, 10 years from now, next year will be so much better than where we are today, because we've seen huge progress, and and the sky's the limit for how far we can go.
Absolutely. Jen, I'm wondering if you can dig a little bit deeper into the trial section and sort of share with people what the role of people with diabetes in clinical trials can be in getting us to that ultimate goal of less burden, easier management, or, we're all hoping, a cure someday.
Absolutely. I think it's definitely remaining engaged. There's so many trials out there. We are eager to find participants. And so I have to say, as a researcher, I'm trying to be very thoughtful about how we design our trials. I don't want to be overly burdensome. We're having individuals with diabetes, not just the people who are a doctor creating the study, telling us, is this too much? Are we doing more than you would feel comfortable participating in? But that's going to push things forward. I have a number of technology trials that are starting. I have a number of trials looking at new immunotherapies in people with new onset diabetes. I have trials looking at apps to help with mindfulness. We are exploring as much as we can. And so literally clinicaltrials.gov, you can type in type 1 diabetes, you can click your age, you can click where you live, and you can say, okay, let's go ahead and see what trials are open to me. Take a look. I try to participate in them because I feel like I have to give back. And I also will say, if I'm asking everybody to do my trials, I need to do them as well. So I'm grateful to all the people who choose to participate. It doesn't take much. And really, it's such a world of benefit that, I did the studies of nasal glucagon years ago. I led it. I got to do the pediatric studies. Those kids come back and say, I did that. They did, So it's getting to that next breakthrough. So.
Yeah, and I think that that's such a good point, because there's all sorts of different trials. There are one-day trials and long month trials and complete surveys online trials. There's so many different kinds of ways that people can participate, and all the participation is important and valuable in moving us forward. So thank you so much for highlighting that. I did a trial on CGMs years ago when I lived in Philadelphia, and I still feel responsible for having a part in our CGMs being more accurate and better. So I actually want to jump into some of our audience questions. So we've got lots of people online today. Thank you all for joining us. We hope you've been enjoying the conversation. We've been so busy chatting, I haven't been able to look at too many of the comments, but I did see that there was an early question about alarm fatigue. And Philly, I'm going to throw this to you first, just to see if there's any dQ&A data on what happens when there are too many alarms? Do people stop responding? Do they stop using tech? Do they just ignore it? Is there any information out there that we can look at and try to learn from?
Yeah, thank you. I will. So one of the interesting, dQ&A tracks the experience over time. So we've been doing this since 2009, and we've seen patients start devices and stop devices and change devices, which is really a fun experience. It is more rare for us to see someone stop using a CGM than it is for us to see folks stop using a pump, for understandable kind of reasons, I think. But we do know that alarm fatigue is challenging, and it is just personally, I don't take my CGM off, but there are definitely times, and this is just my shameful diabetes situation, but I exit out of the app and it gives me the alert that's all mad at me for exiting out of the app. But sometimes it's to your earlier comment about I've addressed this, but my blood sugar is still responding, and then the CGM has to catch up. is the way that it is. And so sometimes, it's 1 a.m. I've had a plethora of carbohydrates and I'm still getting an alarm, and I just can't, like, I would prefer to go back to sleep 5 minutes earlier than it would 10 minutes later. I am hoping, I understand from a kind of safety perspective and from an industry perspective, they're trying to get things through the FDA. They're trying to get devices approved to be used with a bunch of different kind of iOS or Android, operating systems. And I'm sure there's so much there. But one of the things that I really am hoping for later on is more customizable alerts, and also a greater trust in people with diabetes to understand when an alert can't be turned off and when it is okay for me to turn it off. Because I think it's really, really rare, especially for those of us that are managing it ourselves. I know for parents it's slightly different, but it's very rare, I think, that I'm not aware of the danger. It's kind of an ever-pressing issue for me. So I would like the agency to be able to turn off an alarm, because I feel like I know my body good enough to know that I've eaten this many carbohydrates. So there's this kind of, I empathize with how much the CGM organizations are doing for us, and truly I'm so grateful. But I do also just know I'd like to kind of throw my phone across the room sometimes with the amount of alarms that I'm getting. And also I used to have the the bands, the upper and lower bands, very tight, and then I had to kind of expand them, because it would be like, I'm 183 and now I'm out of range, and so getting alarms, and now I'm 174 and then I'm 185, because it changes just a slight amount, and so you end up getting alarms for 3 hours straight. So yes, I am hoping, and I do think that we've seen this in some of the newer iterations of CGMs. We've seen greater kind of discretion that is left up to the patient. I'm hoping that will continue, and I think as we get better technology and as we get better solutions, and as people suffer fewer really dangerous lows, that hopefully more and more freedom will come with that.
Yes, it would be great if between a parent, the person living with diabetes, and the healthcare provider, we could make the decisions that were best for us. Yeah. That's great, guys. I would love that. All right. I want to get to another question that we had from the audience, which is about a complication that we didn't have the chance to talk to just because of time limitations. But vision impairment in people with diabetes is a huge issue. It's a huge concern. And so there was a question that came up about whether or not that there are plans for insulin pumps and AID systems to be more accessible to people who have vision impairment. And I'm not sure if any of you are connected to any trials or have any information you could share, but we would love to hear that if you do.
Sure. I have a small amount because one of sorry to monopolize, but one of the things that we hear is not just the visual impairment, but also the tactile, kind of the inability, and especially when we talk about putting on a CGM or being able to actually press the buttons. If you're dealing with neuropathy, if you're dealing with vision impairment, it gets more and more challenging. And so one of the things that we've really been advocating for recently in dQ&A's work is improving kind of the options that exist. And some of that is coming with the ability to now bolus from a phone, which maybe has more technology available to manage visual impairment. And then also kind of simplified insulin pump dosing options, which are like based off of a finger like click or a push instead of exclusively a screen. Especially some of the pump screens are tiny. If you're not in good lighting, you can't even see it, even if you have 20/20 vision. So we do hear that, and I think that industry is hearing that and responding to that. But it's something that we have centered recently. We spoke in an interview with someone recently who stopped using a CGM for a period of time because she was not able to actually insert the CGM on her, like partly the territory, how much body space you have, and also the ability to actually pinch or insert is very challenging. So I'm hopeful we do see some kind of progress being made there, but again, participating in trials and participating in research like ours or like T1D exchanges is really important for that, because there needs to be enough of us to actually move industry forward.
Yes, absolutely. Jennifer, did you have something you wanted to
add? And as a pediatric endocrinologist, I don't see this, but I've heard from my adult colleagues that they've found workarounds using things like, with a mobile phone, bolus people being able to implement ways to have different messages go ahead and connect in. Again, I think these are people who are highly educated, creating workarounds. But if people can create workarounds, it can be done. The possibility exists. And I definitely think those tactile ones are huge, and we hear a lot about that. But I'm hopeful we're going to just keep expanding the breadth of individuals who we're going to make technologies accessible to.
And can I add not so much on just a related topic? I think on our own end, T1D Exchange, working with the clinics, one of the things we're really trying to emphasize is actually screening for retinopathy, nephropathy, neuropathy, and I think that most times the clinic visits get concentrated on, let me see, your CGM tracings, where you have things going, and like let's zooming in on like the insulin and what adjustments I need to make to insulin. But we're finding that we're living longer. People are living longer with type 1. The oldest person in our cohorts now in the clinics we work with is 97 years old. And those are long lives, beautiful long lives. And the reason why I bring that up is we're working with the centers that are part of our consortium to really think about how do we reimagine the process of screening and identifying people very early on that might be at risk of any of these complications, or even at the early stage of that. Because the beautiful thing about some of this is that we can catch them early enough. There's an opportunity for us to try to do something about it. So, and I say that also to emphasize the role of talking to your providers about this. Talk to your provider about, like, doc, should I be having an eye exam? Or, I was on this panel and they were talking about kidney screening, and they were talking about kidney disease or neuropathy. What's your process here? So we, people living with type 1, get engaged in this conversation and bring it up, because it's not out of the knowledge not being there, but our health system is so fragmented that sometimes it does take that active partnership to ensure we don't miss any of these things.
So we also got a question from the audience about exercise and type 1 diabetes. And we had talked about this, and I think we could have another hour-long session designated just to this topic, actually several of the topics. But Osagie, I just wondered if you could maybe share some thoughts on how people with type 1 diabetes can manage the challenges of exercise while being on insulin, while dealing with hypos. I mean, it's a lot. And we don't want people to have to, consume all the calories they just burned, but we want to encourage a healthy pattern of, exercising as a behavior, not, a challenge.
Yeah. Well, first off is we need exercise, and people with type 1 diabetes, exercise needs to be part of our routine, needs to be part of our well-being. And there have been several studies published in many literatures that should have shown that yes, this is key, this is important. To give a 30 seconds answer to your question, I'll say start small, and there's going to be a lot of learning from the process. You need to think about how long the exercise is going to be. You need to think about the type of exercise. Is it an aerobic one? Is it anaerobic? Is it a short sprint? Is it a long sprint? What time of the day is it? When was your last meal? How much insulin you have on board? And I'm not saying any of that to overwhelm us, but I'm just saying that it's important that you're going to have to understand all of the critical components of how your body responds to exercise, the type of exercise. There are many resources online as well to really help with this, and even talking with your provider around how can I be safer in exercise. And the last piece I'll add is let someone be aware that you're going on an exercise, particularly if it's a long exercise. You're going for an hour, taking a run. Let someone down, like a spouse or a partner, a friend. Oh, I'm going for a run for an hour. Just again, it's creating that community and not out of fear, but really out of responsibility, understanding this.
Yes, that's huge. And I do think that the more consistently I have added exercise into my routine with no insulin on board, the much easier and productive it's become. So I encourage you all to find ways to include that. Unfortunately, that is all the time that we have for questions. I feel like the four of us should have a podcast. I could talk to you all for hours. It's been such a delight. I am so grateful for all of the work that you guys are doing in our community and for all the information that you shared today. Thank you so much for being part of this important discussion. A huge thanks to our sponsors for making diaTribe's Musings free events, to everybody who is able to join us tonight. I did want to let you know that we will be keeping this platform open for an additional 30 minutes so you can take part in the community networking feature. You can just click on the networking icon on the far left of your screen and you will be randomly joined into conversations with other people who were either on the panel today or in the community, and so we encourage you all to do that. And then you can move on and meet. It's sort of like speed dating. So I hope that you guys all enjoyed this conversation. I cannot thank the three panelists enough. It has been such a delight getting to know you, learning more, and working to educate everybody so that we can all live happier, healthier lives with diabetes and really continue to move things forward so that in another 26 years, we're all still in the same wonderful shape that we're in now. And maybe there's even, something better to look forward to, like a cure. So thank you all again for joining us today. And thank you to our panelists. I hope you guys enjoy the rest of your evening. And thank you so much for joining diaTribe for this event.